So, as people are coming in, we are going to get started so we can get to this fantastic presentation. My name is Dr. Cassie DeSena Jacobs. I am a faculty member here at the School of Social Work, and I am the Director of Mental Health Initiatives. I'm joined today by Clara Pratcher, who is our Assistant Director of Mental Health Initiatives. So you will see us managing the chat and answering any questions that you have. We are so thrilled to have Sara Tolentino here with us. Sara is a LCSW with over 27 years of experience in community mental health and substance abuse services at Henrico Area Mental Health and Developmental Services. Throughout her career, she has served in multiple capacities, including as a case manager, clinician, clinical supervisor, and program manager, working with high acuity populations across a wide range of settings. Her leadership experience includes supervising the most intensive community-based programs, such as assertive community treatment and intensive community treatment teams. And in recent years, she has managed all behavioral health and diversion services for both Henrico County jails, leading forensic mental health initiatives and supporting justice-involved individuals. Um, that's not it, though. Sara has also served as a hostage negotiator for Henrico County. She's a certified Red Cross first aid and CPR trainer, and she represents the locality on Virginia State Early Diversion to Court-Ordered Treatment Committee. She brings a deep commitment to crisis response, system-level collaboration, and trauma-informed care for underserved and vulnerable populations. Luckily, Sara does have a good work-life balance because when she's not at work, she enjoys baking and spending time with her two adult sons and her cat, Winston. I think we're really privileged to have Sara here. Sara is also a instructor here in the social work and mental health minor, and we're thrilled that she's going to be talking to us today about open dialogue. Some very quick housekeeping pieces. You will see us put the attendance sheet in the chat after 7 p.m. So if you'd like to make sure that you get your certificate for attending today, it is 2 continuing ed credits. Make sure that you keep an eye out. Either Clara or I will be putting it in the chat after 7 p.m. But we're going to be turning it over to Sara. The other thing we want to mention is Sara does have a video. My Zoom is having some issues, so we will be putting the video in the chat and we will ask you to watch that video because Sara is going to have a collaborative conversation about that video. I think that that's all. I want to make sure Sara gets to have the conversation, so I'm turning it over to Sara. Thank you so much. You're muted, Sara.
I'm muted, and thank you so much for that wonderful introduction. I appreciate it. That was an amazing bio. I think maybe I did write some of it at one point. I don't remember, but I appreciate you guys having me. It is an honor and a privilege to be here. I will say I've done all those amazing things, but I can't figure out how to my slide my slide mover has disappeared. So give me a second while I figure that out because I don't know where that's gone. But what I will say is I will start just kind of talking until I can figure out the slide thing because it may take me a minute to do that. I have no idea where it went. You guys know, those of you, I know several of you in the crowd and you know technology is not my thing. But I do have a lot of mental health experience, and I have to give a shout out to VCU. I am a RAM. I graduated from the distance ed program in 2017 with my MSW. And I am so thankful that they started that program. And I was in the second cohort of the distance ed program. So really appreciate coming back to home to VCU and being able to work with the wonderful folks there. So thank you. I will hopefully figure out the slide advancement thing. Can anybody help me? When your slide thing goes away, where does it go? You all are good friends, right?
Sara, I was doing the same thing at 8:15 this morning, trying to get my class going. I'm like, hey, y'all, where did this thing go?
I don't know. I may stop sharing for a second to see if I can find it.
Yeah,
Sorry
sure,
about
go
this.
for it.
I do apologize. Let's see.
You're fine, Sara.
My apologies. All right, let's stop sharing for just a second. Probably now it's not in presenter mode, right?
No.
Well, I'll get there eventually, guys. I apologize for this. I had it all set up. We had it, Cassie and I got on here earlier to get it all set up, and now it's not working for some reason. Is it working now?
Yes.
Okay, I don't know. I still can't find my advanced thing. This is really going to be an issue, I think, for me. I so apologize. Wait. Oh, okay. I think we're back in business. Look at that. Problem solving. All right. Well, thank you all again for having me while we work through the technical difficulties. I really appreciate your patience with me. I am going to talk to you guys tonight about open dialogue, also known as OD. And I'll tell you, having done this working with especially the SMI population, co-occurring population for a long time, as you heard, 27 years, many years, I realized, that not all the treatments that we utilize, even the evidence-based ones, work for everybody. And I had an interest in exploring different kinds of treatments, especially from different countries and in different areas, to try to do something different for those we serve to help. There are a lot of, treatment-resistant folks in the places where I've worked. Although I don't really believe in treatment-resistant folks, I believe that our treatment is not correct for those folks, right? It's not that they're treatment-resistant. We just haven't found the right treatment. So I did a lot of research and a lot of searching about different areas, different countries, and what was available to be utilized that was at least somewhat evidence-based, right? Because we want to be using evidence-based practice. And I came across open dialogue. And open dialogue was, we were going to do a meditation, but you guys got a break with me trying to find my slides. So we're not going to do a meditation, even though I probably need it. Y'all probably need it after having to listen to me flubber with the slides, but that's okay. Open dialogue began in Finland, in Toriano, Finland, I am all a mess. Open dialogue began in Toriano, Finland, in Toriano, Finland, in Western Lapland. And it's a really interesting place of Finland. It is a place that gets very little sunlight. And it is also a place that there was a very high incidence of individuals diagnosed with schizophrenia. There was like 35% of the population there was diagnosed with schizophrenia, and a very, very high unemployment rate. So it was a very dark, very impoverished, and very ill population that was living in this area in Finland. And in 1979, there was a code change in the law in Finland. They had two mental health hospitals there. One was an acute hospital for short-term stays, and one was a longer-term hospital for really like long-term, kind of like our state hospitals here in Virginia. I would say like Central State, Western State, places like that. And then you had the other hospital, the acute short-term stays, kind of like our St. Mary's, our Richmond Communities, hospitals of that nature. So the code change saying that they could no longer have the long-term hospitals, kind of like when our state hospitals were shrinking and people were being placed into the community. It's very, very similar to that. And I love the fact that Finland and some of the folks that we're going to talk about today decided to utilize that code change, that change in hospital, to actually come up with a new type of care, which was open dialogue. So open dialogue really came out of, and I'm going to butcher these names, but Karapudaras was the hospital epicenter of development. And that was the hospital that needed to go from a long-term hospital to a short-term hospital. And so these group of individuals, whose names are on the screen, and I'm probably not going to try to pronounce because I will butcher them, they were all working in the hospital at this time. They were all tasked with kind of making these changes in their mental health system. And they're the founders of open dialogue, if you will. And they started slowly evolving the process. What they realized was that people were really ill. People were getting traditional treatments. They were on not a lot of neuroleptic medications and not really getting that better. So what can we do to help people? And they kind of took over this hospital. And what they did was they called families and would involve families and would involve social networks. And the families would say to them, no one has contacted us about our loved one. No one has reached out to us about how we can be a part of our client's treatment. And so there was a lot of, I think, mistrust of the hospital system, mistrust of the medical model and the system, kind of similar to what we have, I think, a lot of times in the United States. I think it's very similar. And they started trying to engage the families in care, which now we kind of do regularly. But back then, I don't think that was really not something that was done, especially in Finland. And they really started to focus on person-centered care. And so what they started to do was have the families come to the hospital to be a part of the treatment. And they would have these things called network meetings, which we're going to talk a lot about today. And it's one of the things that we're going to watch a video about today. You guys will have to do that on your own because of the Zoom issue, as Cassie mentioned. But they started having the families. And initially what they did was they would have the patients admitted to hospital, and then the families would come and they would have these meetings. And people were getting better. People weren't needing medication. They were building a social network, right? And they started doing reflections and dialogues that we'll get into throughout the training. But interestingly enough, they liked that model so much and the engagement of these other individuals in folks' care that they began to do the meetings before hospital. So you would have a person in crisis, and a lot of the literature on this is about psychotic process because that's initially how this was utilized. It's utilized for all kinds of diagnoses now, but initially it was psychotic, usually the psychotic disorders that this was utilized for, open dialogue. But they would start having, somebody would need a hospital, they would have a team respond, and they would do these network and open dialogue meetings, and they would be able to decide, and they would decide what the course of treatment would be. And in doing these meetings this way, what they found, and we're going to talk a lot more about this as we go on, what they found that there was a 30% reduction in hospital admissions when they went out into the community, saw the patients in their natural environment, met with the family support network. They were able to reduce hospital admissions by 30%. And you think about that, 30% is a huge amount of people. Imagine being able to do that for somebody, because we all know how trauma-inducing and how difficult it is to be in a hospital, whether it be for a medical reason or a mental health reason, probably even more so for a mental health reason, for a mental health admission, I think, in a lot of ways. So that's kind of the birth of how, that's kind of the birth and how open dialogue came to be. It was officially coined open dialogue in 1995. The folks that are on my screen, the names who are on my screen, who I'm not going to say because I don't want to butcher them, were all trained heavily in family therapy. They had done a lot of, that was psychoanalytical work, and family therapy work was really the work that they did. The work was heavily influenced by Tom Andreessen, he did a lot of work in need adaptive treatment back then, and in a lot in family therapy. So that's how open dialogue, just the history of it. It started in Finland. It became it's a very widely practiced modality of treatment in Finland. So to talk a little bit about the historical and the theoretical foundations, like I said, it was a family systems therapy kind of network. It involves a network of folks, that the service user, which is what they call patients in Finland, and I think that's kind of a neat name, service users. The service users would be able to obviously decide who their network would be and who would participate in what's called a network meeting, which we're going to talk about much in great detail later. The interesting thing about the development of open dialogue is that the social construction of psychosis symptoms and crisis was really an important component. And you know, as the medical model kind of defines mental illness is a biological disease. Folks don't have the proper chemicals. We all know kind of what that looks like. Psychosis is due to having, excessive dopamine, and that we all know what kind of how that looks and how that works. But they really took psychosis as the meaning had to come from the patient, and the meaning had to come from the family and the network of folks that supported it. So it wasn't about what we thought as practitioners. It was really about what the family thought. And that is one of the beautiful things about this model, is that the narrative comes from the family and the patients. It doesn't come from the providers. And that's a huge difference, I think, than a lot of the practices that we do now. I will say that the language approach is incredibly important in open dialogue. You're utilizing polyphony, and you're utilizing vertical and horizontal dialogue. You want, in a network meeting, which we're going to talk about, like I said, you have all of the family or the people in the room supporting the service user, and you want there to be dialogue, obviously, amongst them, but you also want there to be dialogue internally. So we'll talk a lot about that. It was a huge part of a recovery movement, of really recognizing that recovery is very different for individuals. It's not linear, and that everybody has a different path to recovery. And it's all about relationships. At the end of the day, I think that we all know that everything is about relationships. So that's kind of the theoretical and historical foundations of open dialogue. It really was created out of the hospital system, and a hospital system that needed changing. And it was rooted in family therapy. And in social supports, clearly. They had a lot of training in a lot of those things. When you think about all of the things that open dialogue encompasses, it's a bit different than the systems that we currently utilize. Immediate help is the first tenet of open dialogue. When somebody calls and they want assistance, let's say they call the CSB and they want assistance. How does that look? It looks like, okay, well, come in and do same day access. And then in a week and a half or 2 weeks, you will then see your case manager, and then you'll see your prescriber. Or you guys know the wait times for therapists right now, they're really long. So immediate help, response within 24 hours is one of the core elements. Social network perspective, as I said, the service user determines who else is involved in their treatment. And we'll talk about that a lot, because some of our folks that we work with, some of our individuals don't have a social network. They may not have anyone, but it doesn't have to be family. It can be your boss. It could be your cousin, or it could be, if your grandma was still alive, what would she say? So that's an interesting part of open dialogue. Flexibility and mobility. So one of the great things about this model of care is that you go to the client. The client can come to you, or the client's family can come to you, but you often deliver service in the homes of patients or in the park. Obviously, you have to worry about confidentiality, but you go to where people need you to go. And I think that responsiveness, as we've learned with MRT and some of the ACT and some of the other service provision, it is very important to be able to go to people and meet them where they are, figuratively and literally, right? Responsibility. So if I'm working in a clinic that's practicing open dialogue, and I take that initial phone call from the service user wanting services, or the family member wanting services, I am responsible then for following that family. Continuity of care. I think we all know how important that is. Psychological continuity is so important. Tolerance of uncertainty and dialogue and polyphony, and we'll talk about that more as we go. So I've kind of gone over some of this. Immediate help within 24 hours of initial call. There should be a meeting scheduled. Meetings are scheduled at the request of the service user at any time during ongoing treatment. The service user or the patient or the client is the driver of the treatment. The service user is asked, as I said, who they want to be included in the network meetings. The model values connection. All voices are heard, valued, and respected. As I said, meetings are often in the client's home, and they're scheduled based on service users' needs, not according to organizational hours or clinician schedule. And we'll talk about that later. One of the difficult things about implementing this model is that it's not on our time. It's on the client's time. And we all like our little, 8:30 to 5 jobs, and that's not how this works, which I think is interesting. As I said, responsibility, whoever takes the initial call is responsible for coordinating the meeting and responsible for out. The same professionals, and this is really hard with turnover, but you always have at least, hopefully, one of the people is maintaining employment at the place that's providing the service, because one of the tenets is that you continue on with at least one person throughout the course of treatment. It's not like, you come here and I see you for a while and then you go see somebody else, which promotes trust and connection and limits the startovers that we often see in traditional treatment. The other thing, the other core element of OD, and we'll get into this more later, is the tolerance of uncertainty. There is no preconceived plan. There's no clinical service provider assessment, no preconceived notions. I'm not sitting here saying, okay, we're going to diagnose you. I'm going to do an ASAM. I'm going to do a comprehensive needs assessment, a PHQ-9 at Columbia. There is none of that. There is none of that in open dialogue, which is probably why I find it so appealing, because you don't have to do all those assessments. This is another really interesting component of open dialogue, is that service providers do not talk about cases outside of meeting with the users. So you guys know, I think many of you are obviously in the field and interested in this kind of work. We talk about clients in team meetings and supervision. They do have supervision about cases, but it's called intervision. And it's where it's more of a dialogue about not necessarily the clients, but about our work and what it is we're doing and how can we do a better job, right? It's not, so intervision versus supervision is an interesting component, and we'll talk a little bit more about that later. Dialogue is the intervention. Service providers elicit conversation amongst and within participants. The network builds a shared understanding of the crisis, and the approach helps to highlight the problem that exists, not just within the service user, but across the not just within the service user, but across individuals. So this is not just about, we have this patient, their family's going to come in, we're going to focus on this patient. That is not what open dialogue is. Open dialogue is us creating a conversation, utilizing the network and the patient, and having them construct what they view the problem to be in their words. It is not about what we think the problem is or what we think the family needs. It is about what the family believes. And it is a different approach. Again, it is very unlike the medical model in that we diagnose and we do all these things. There is obviously, you have to diagnose at some point, and you talk to the family about that, but all of the information comes from the family and not in a structured way. Let's see. So network meetings are really the main component of this treatment. And it's what I've been kind of alluding to and talking about all along. And you have 2 or more therapists in a network meeting. It is never just a single therapist alone. And the reason for that is you do what is called reflections, where you will start the network meeting, which is you have the service user and their families there, and you would say, tell us what the purpose today of this meeting is. And you would go around to every single person in the room and have them explain what they thought the purpose of the meeting and what they wanted to get out of the meeting was. And you would go from there. And so one of the other things that we're going to talk about is tolerating uncertainty, because there's no plan. There's no plan. And that's different for us. We usually have a plan when we're meeting and working with people. So it really is, you kind of you go where the client takes you, and you create, your job is to create dialogue. Your job is to create a story, help the client create a story about what's happened to them, why they are where they are, so that they can make sense of what's happening to them, especially when it comes to psychosis, because that is oftentimes, this is originally what this open dialogue was intended to treat. As a therapist, you are asking open-ended questions. You are not obviously asking yes/no questions. You respond to clients' utterances. You repeat back clients' words, and you don't paraphrase. You do it word for word. What they say, you say back. You elicit multiple viewpoints. If you're doing a good job at open dialogue, everybody in the room is speaking. Everybody has a chance to speak. It really is the use of a relational focus, which is a really important component to the network meeting. You have responses to discourse. You're attentive to meaning of things to folks, reflections among professionals in the meeting. So how it works is everybody will be speaking, and then you would say to the group, we really appreciate all you're sharing with us today. Would you mind if Clara and I had a conversation about what we've seen here today? And then Clara and I would engage in a conversation, and it would just be, let's say we're meeting with a family and the client's name is John, and I would say, I felt really heavy in my stomach when John was talking about how it was for him when he was assaulted. You would just kind of utilize yourself as a tool, and you would have a reflection, and you would repeat back what people said, and you would kind of comment on it very matter of factly. It is a very factual process, and you would then turn to the family and ask them to comment on the conversation that they just observed. Isn't that a different concept? That is such a different concept for us to have a conversation as therapists, very transparently and authentically in front of our clients. And then they are allowed to then give us feedback. And that is one of the things I love about it. And that's when we get to talking about later about how it really addresses cultural mistrust and really meets people where they are. It's one of the main components that I so appreciate. There's a lot of transparency, and of course you're tolerating uncertainty because you don't know what's going to happen in that meeting and what people are going to say. You don't have no idea, which is one of the beautiful things about it. So that's kind of an overview of open dialogue, how it started. I know it's a little confusing because it's such a different way of delivering service, but we will be watching in a little bit a video of an actual network meeting, which I want you guys to see so that we can then talk about that a little bit after you watch it. There's a link to that in the chat. But I wanted to kind of pause for a second to see if anybody have any questions about anything that I've shared so far. No questions? Has anybody ever heard of open dialogue before? Anybody practiced it?
I actually have a quick question. I don't know if this is a silly one too.
Never a silly question.
You had mentioned before, oh my God, the horizontal and vertical dialogue. What? I've never heard of that. What is that?
So vertical dialogue is a dialogue within yourself about what's happening.
Oh, okay. That makes sense.
Yeah. So I want you to be thinking about what you're saying, what's happening within you, what's going on within you. And so you're trying to create that in people, and then also trying to create the horizontal dialogue amongst the individuals in the room.
Okay, got it. Thank you.
Sarah, I think Dylan was unmuting. If I can go to Dylan. Sorry, Dylan, to put you on the spot. I watched you, and then you do have 2 questions in the chat. So hi, Dylan. I watched you on mute.
Yeah, hey,
no pressure.
Grateful to be here, and thank you for your attentiveness, Dr. DeSena Jacobs, and also very grateful for this opportunity to learn about open dialogue. So I heard like elements of narrative in this, narrative therapy, narrative theory. And you may have covered this, but in terms of this kind of departing from what seems like more of a medical model, and what's the footing that OD has within like Western treatment modalities, and like is it gaining any more traction or footing? Have you seen?
Yeah, it is actually gaining some traction and footing. There's a couple of Graft Hospital in Atlanta utilizes it. There's a Open Dialogue Institute, Yale, does some work. There's an Open Dialogue Institute in New York City, Massachusetts. There's several clinics and areas in Massachusetts that utilize it as a form of treatment. We'll talk about the barriers to having it as a treatment modality in the US, because there's a lot of barriers, definitely there are. Insurance billing, the timing of it, there's a lot, and the training. I did a 2-day training in Open Dialogue. There's lots of and as we go through, you guys will have access to these slides, I'm imagining. I included some links to trainings. There's a training coming up, I believe, in April that's online. I think it's about $300. There's various aspects of training, which we'll talk about also. But it is gaining traction. It is gaining traction in the US as a practice modality.
And if I may, real quickly, you said that you'll discuss the barriers, but what have you found in terms of culture shift or things shifting paradigmatically that's given it the ability to have more footing? What do you think is changing?
I think what's changing is that people are realizing that treatment as usual doesn't always work for individuals. And I think that in a response to individuals, us not being the experts all the time, I think we're starting to get that we're not the experts, that people are really the experts in their own lives. I also think that there's a lot of research being done on this. It's not, I'm not an academic. So, I mean, I'm not the way like some folks are, right? But it's a hard thing to study. There's a couple of, there's no manualized treatment for it per se. The treatment is years long. Some of the training is years long for the really true experts that do this day in and day out. And it's spread out over time. It's not 3 years of intensive treatment, intensive training. It's spread out. But I think that one of the things that makes it a barrier is that it requires a lot of training. It requires a lot of time. You have 2 therapists in the room. It's after hours. There's a lot of different things that are making it difficult to fully implement.
Thank you very much for that.
Thank you for the question. I appreciate it. Good question.
For those of you that are students that want to take the mental health classes, we do talk about this in the SMI class, but this is a much more in-depth conversation. So, Sarah, we may ask you if we can pull this and lecture into the SMI classes, but we do talk about this in those classes as well. Sarah, your next question in the chat is, how many people are typically in a network meeting?
It can be 2 people or it could be 16 people. So it really is up to the service user. I have done this work. Again, I had a 2-day training. I'm eclectic. You all know who know me know I'm eclectic. I do all kinds of things. I practice. I don't do any harm. I swear I don't. But I like to try new things and practice new things, especially if I have people that are not getting better with what I'm doing. I think it's really important that we do try different things. So when I worked on the PACT team, because PACT is a really great place to do this work because you're already in the community, you can afford to have a clinician and a doc go out at the same time, or a clinician and a nurse go out at the same time. And so I had a network meeting where the client was incredibly paranoid. They were okay with having the meeting, obviously, or we wouldn't have been able to do it, but they wouldn't come in the room. But we had the meeting and they were in another room, and it was the parents and a grandma that was participating in the network meeting. And the interesting and neat thing about it was the client was overhearing and listening, and eventually they came into the room as they were hearing. So it really is dependent on the service user. It really is client centric. And so we would ask who to have in the room. I think 16 would be a lot. That would be a lot for even two therapists to manage, but it really is up to the discretion of the service user.
Sarah, you're doing a great job. I'm like loving all of your answers, just so you know, and I think you're getting that vibe from the audience as well. Next question you have is, and if you've been able to implement any of the tenets in your own practice, and the person does note that you can answer this at the end if you'd like to.
Yes. So yes, I have been able to do some of this in my own practice. Like I said, when I was doing PACT, we were able to do some of this work. The nature of the PACT team just kind of lends to it because, as I mentioned before, all of the the reasons. I also, I work at the jail now, and I'm also able to utilize it some there. It's obviously very difficult in that environment due to the confinement and not having networks available. But you can still we've done a couple of Zooms or a couple of WebExes where family has joined. We've had the inmate sitting there, and we've been able to do the dialogue and be able to have the conversation. It is very matter of fact. Like I said, it's very letting them come up with, create their own story. And I will say that you can also do things like, well, your grandma's not here, but what would you grandma say? Let's talk about, tell me what your grandma would say if she were here. A big part of the training, and I'm jumping all over the place and I apologize, but a big part of the training in this is self-work. And so you have to be incredibly mindful. You have to be in the moment. You have to be so in tune with what's going on in the room during one of these meetings that a lot of the training, I'll tell you now since the question was raised, but genograms, family history, it is a lot of self-work and self-reflection going through the training to be an open dialogue therapist or practitioner. So I have been able to do some of the tenets and do some of this work. Not the way somebody who's been trained and done the whole 3-year series has, for sure. I'm not anywhere near that good at it, but it's definitely, it's near and dear to my heart because it really levels the playing field. The hierarchy is diminished. We are all on the same level and same field with our clients when we use this network, this open dialogue.
Speaker.
Does anyone else have any last questions for Sara before she moves on?
Thank you.
In terms of reflexivity, in terms of being reflexive and that awareness within the practitioner, like why do you see that as being very important or necessary for OD?
Because you have to pay attention to every little thing that's happening in the room to try to elicit conversation in a nondescript way, in a non-directive way. You can't elicit conversation, you can't elicit participation without being completely in tune, and you feel it in your body, and you utilize your own experience in those meetings as part of the reflection. If that makes sense.
Thank you.
Sure.
Sara, those were all the questions in the chat. So
okay, great.
Thank you.
Sure. If there are no other questions, I think what I would like folks to do, Cassie, is to watch 15 to 20 minutes of this video, maybe 15 minutes of this video. I'm sorry that I didn't have somebody to practice this with me in front of you guys, but and we don't have any actors. So I didn't have any actors. So I think that if Cassie put in the chat this video, and what I would like for you guys to do is to watch the video, and then we're going to come back and talk about it and continue on with the training. But this is a video, and you've got subtitles, but this is it's the only really good video I could find of an open dialogue network meeting. So if you all can watch that, and then we can get back together and talk about it. But 15 to 20 minutes.
Yeah, so you're saying, so what time exactly do you want them to come back? I had said 6:57. That's 17 minutes. Are you thinking?
Good.
Okay, so come back at 6:57, everyone. We'll turn off our cameras and we'll all rejoin at 6:57. Thank you, everyone. If you can come back, we're gonna turn our attention back to Sarah.
Welcome back. So what did people, any comments about the video? Any thoughts about it?
Were we supposed to have been able to finish the whole thing? I think it was like,
No,
okay, okay.
no.
Just checking.
Yeah, and I do think it's important if you could, if you have time and you're curious about it, I do think watching it to the end would make sense because in the end there's a reflection, and I think that's a really important component for you guys to see. But any thoughts about it?
Sarah, when I was watching it, what I really appreciated is this idea that the facilitator was really decentralized. Like it's not like they were the expert. They really kind of ingrained themselves into the family and were just facilitating conversation. So I really
Mhm.
like that idea of being decentralized as a clinician.
That really is, Claire, that's a beautiful word. It really is being decentralized and allowing and facilitating and allowing and creating space for that conversation to happen. When if you guys watch through to the end of the video, you'll see when during the reflection between the two therapists, they just kind of are commenting on what they heard and no judgment. It's very matter of fact. And the one of the clinicians says, I think Carlos has more inside that he wants to share, but we really respect that he's sharing what he's sharing now. Kind of opening that up to allow him to share more, but also letting him know it's okay that you're not doing that right now. I noticed that there was a question in the chat that what do you do when you run into a situation when you have one person who wants to take over the conversation in the group? Haven't we all been there as therapists? And I think what you do in that situation is you matter of factly say, I'm noticing that you're having a lot to say in this conversation. I'd like to hear what Mary has to say. And I thank you for you're saying that, and I'd like to hear what Mary has to say. So that's kind of how you go back and forth between when you have somebody who wants to overtalk. You point it out, and then you keep it moving to somebody else. Reminds me of the yeah. So anyway, that is open. That is an example of an open dialogue. It's very calming. It's very, and that I think maybe from that you got the sense of why you have to be so present in those meetings, because it's really important that you stay that way. So that I'm glad you all. Oops, sorry, I'm glad you all got to see that. The 12 key elements really of this practice are participation of the family in the network, utilizing, I don't know if you've noticed all the open-ended questions that they utilized, being matter of fact, responding to clients' utterances. When clients say, if they say a sentence, you repeat the last two words, last three words, whatever makes sense. Emphasizing the present moment. We're not necessarily talking about what happened 3 years ago. We're talking about that we can, but we're also really keeping it in the here and now. And we really emphasize the client's stories and words, not their symptoms. And we don't call them symptoms either, which is really important. Being transparent. And again, you saw the tolerating uncertainty. Those therapists had no idea what was going to happen, what was going to be said in the next minute, next second. So it's really tolerating uncertainty, which is why you have to do so much self-reflection and so much self-work to be able to engage in this practice. I'm going to talk a little bit about it. If anybody else has any questions, no more questions. Okay.
You have a couple of questions, Sarah. You had a question from Olivia.
Sorry.
No, it's okay. Sorry. You had a question from Olivia, and then a question from Dylan, and then one from Jasmine or Jasmine. I don't want to get it wrong. So if we can go in that order, first Olivia, then Dylan, and then one in the chat.
You know what? Mine wasn't actually really a question. It was more of a reflection. I just, it was so like just the evenness and calmness that the facilitators had, and that they just kept repeating like the woman just kept having to ask like, and how did that make you feel? Because she would ask that, and then they would answer, but without any feeling words. So just like the ability to keep returning to that question, even if it isn't answered.
Absolutely. Good point.
Now, if we can go to Dylan.
Thank you so much for sharing that video. It was very illuminating, just in terms of getting an idea of what this modality looks like. I'm curious, in terms of it feeling very much like an intervention, it felt like there was potential for it to be received confrontationally by the individual around whom it was centered. And so I'm curious, like, when trying to build to this, like, what session was that? Like, how ready was that individual to be in that dynamic with it feeling like an intervention?
Yeah, I think that was like the fourth or fifth network meeting that family had. So it wasn't, you wouldn't probably go that hard the first couple of meetings. It would be it would be what, tell us the purpose, why you called this meeting, what's the purpose of this meeting. The first meeting, and really there's three purposes to doing these meetings. One is for people to tell their story and become aware, and and to decide treatment too. We are going to, there is a focus on treatment. Like if people decide that they want medication, a psychiatrist can be pulled in. If people decide they want to do, I don't know, EMDR or whatever, there's other ways to incorporate treatment. This is just the model used to kind of get to that place. But I would say that initially discussing why you're here for treatment, and anything that can happen in regular treatment can happen when you're utilizing this methodology. It's just, this is how the initial treatment works, if that makes
Okay.
sense.
It does. Thank you for explaining that. And also, I noticed that the one of the clinicians, the individual with the white shirt, was speaking more than the other clinician. Is that a standard in terms of approach, or is that just how this dynamic works out for this situation?
I think that my guess, I'm guessing, I'm speculating. This is not, I don't know this for sure, but my guess is she's the person that has been with this group from the beginning. And like I said, there's always one, it's great if you can have two people, the same two people in all of the meetings, but the standard is you have one in all the meetings. So based on what I saw in that meeting, and I've watched it several times, and I'm thinking that she's the primary person for that family. And there's been other people in and out. That's my guess.
Thank you.
Thank you. Great questions.
Jasmine, did I pronounce your name wrong? Please correct me before you answer it.
Sure, sure. It's Jasmine. Just an
Jasmine.
extra silent E.
I
Yes, no
remember that
problem.
from Gary's conversation now. Thank you.
Sure. Um, yeah, I also was pretty mesmerized and just want to keep watching it. I some more. I liked I so reflection and then question is really liking, like someone else said, her evenness, because one of the, it made me think of um, old school family therapy training,
Mhm.
which had a lot of these similar components, right? Where,
Yes.
needing to have that posture of openness, acceptance, building a sense of shared collaboration, and why are we here together. That was just so it made me think of that, and it also made me think of the challenges of doing that, that it can just one can get hooked into the affect in the room. The dad had a definite posture. Every time the
Yes, he
camera would
did.
go, he'd be like, you know, and
Look at
and
me.
yeah, yeah, it was really and so I really enjoyed the therapist feeling like an artist that is just open to whichever way this brushstroke takes you,
Mhm.
and following the lead of, and knowing that, though intentionally, that the we would have called it the identified patient, that the
Yes.
person who is um uh who's maybe feeling acted upon has some voice to share. So it kind of there was a definite intentionality in what was being done and how it was being done. And my question is, so in the term open dialogue, because so much of this feels like, our core way of
Mhm.
wanting to use ourselves in therapy,
Mhm.
um, is the open dialogue, is it different and I know you shared a lot of ways that it's different, but is it also this idea that the two therapists process their observations openly with the family present?
Absolutely. That is exactly right. You do. That is the whole purpose of the reflection. I love the way you said that. Thank you. That was very succinct and a great explanation. And it really is for the family to receive that feedback. It's a way for the clinicians to be able to kind of process things, but it's also then you give the family the opportunity to comment on what's been said, which I think is, and one of the reasons I think that this practice is just a wonderful practice is because, and I think the reason why there's such an evenness in the therapist, as you mentioned, is that I'm not the expert. I'm not the expert. I'm not here. And by that, I mean, I'm not here to diagnose you. I'm not here to tell you what you need. We're here to figure this out together. Now, is the role of the OD therapist incredibly difficult, as you alluded to? Absolutely. It's very difficult. But I think the cultural mind shift of the paradigm that we're all in this together and we're all equals really helps contribute to your ability to have that evenness in the space.
If we, I'm really moved by what you just said, Sarah. So, oh, that was beautiful. Can we go to Jessica and then you do still have a question in the chat? I didn't miss it, Mickey, so I do see it there. So if we can go to Jessica and then there's Mickey's question in the chat after.
I just wanted to say thank you for sharing this because I'm currently in my final field placement with the behavioral health unit. And so I work on a treatment team with psychiatrists and social workers, nurses, all of the staff that's in that inpatient behavioral health unit. And I just see this as an amazing technique simply because we have a lot of patients that are like repeat patients, and there's a lot of conversation that goes between, they're in a locked unit. And so there's phone calls that have to be made to family members, and like a discharge plan is made, and then a family member calls and they want something different. And I think that this really kind of brings everybody on board. And one of the most humbling things for me is, I've had our staff psychiatrist say, I don't know what to do with this person. So I think that opening this up to their, their network and getting that, because really, I mean, I think we're taught in this program from the very beginning, each person is their own, the expert of who they are and what they do. But I mean, I really appreciate this, and it's very exciting, and I wish that we had the opportunity to do this at my field placement there.
I will say thank you for that. And I agree with you wholeheartedly. And I will say that hospital settings is a really great place to do this work. Now, in Finland and in other places, the practitioners would follow the folks into the community. That would never happen here. But how neat would that be, right? How neat would that be if we could make it work?
That made me laugh, Sarah. Okay. And I like your honesty. I think we all appreciate your honesty, Sarah. It's refreshing and appreciated. Mickey's question is, I noticed that the therapists set soft rules in the beginning. So I noticed the therapist set soft rules in the beginning. Is that something that you implement in your meetings as well?
Yes. And you got to really balance that and be careful, because again, we're not the experts. This is your meeting. Why are you here? But you also can't have, I've had meetings where people have stormed out, where people have been, engaged in a little bit of, violence, throwing things and things of that nature. And you do have to, you do have to say people can come and go as they please. That is absolutely allowed. As I told you, I've had a network meeting where a client was not even in the room. They were in the other room, which was absolutely fine. You completely accept that. But you do have to make sure that everybody in the room is safe, and you do have to set those parameters. So I always say we're here to help. We're here to assist. I offer people the ability to step out if things become overwhelming, if we can take a break when people need to. But you do have to set some rules regarding it, mostly because a lot of these meetings are with people who are experiencing psychotic process. And so you have to be very careful that people feel like they can leave the space if they need to do that.
That was your last question for now, Sarah.
Okay, great. Well, we will go on. We'll talk a little bit about the training. So the trainings are, I did the introductory workshop, which was 2 days. And again, in these slides are the links to a lot of the different websites and a lot of the different institutes that are doing the trainings now. Some of them are in the US and some of them are not, or some of them are overseas. But the introductory workshop really focuses on doing a little bit of self-reflection and self-work, and really learning that dialogical process and learning how to run the network meetings, because it is an art and it is a skill and it's not easy to do. They make it look very easy. It's not that easy. And then, as I mentioned, there are the multi-year programs, which again are spanned over 3 years. You don't do the 3 years of work, obviously, but you do a lot of work on self-reflection. Like I said, the genograms, there are specialized courses in it. And then the use of open dialogue really, really supports peers. And there is a whole peer-supported open dialogue venue. And if you guys are interested in that, I can probably send a link to Cassie and then she can send it out to you, because I don't think I included that. But there is a whole peer open dialogue movement where you have a clinician and you have a peer in the room also. And I think that adds a whole new level and a whole different component to it, because we all know how important lived experience is, and having somebody with lived experience in the room. And I've done a little bit of research and or read some about open dialogue meetings where the peer is actually leading the meeting, and the and kind of the main person, like we noticed with that other therapist kind of taking the lead, where the peer is actually the person taking the lead. And I think that's a really key component to treatment. Let's see. So there's lots of options for training if you guys are interested. And again, the training focus is geograms and family network, a lot of reflective and a lot of self-work, mindfulness sessions. It's a culture shift. It really is a culture shift. It lowers the hierarchy, and it really incorporates a whole different way of thinking about treatment. And then intervision, as I mentioned earlier, it's not really supervision. You really don't talk about clients outside of the network meetings. And I mean, I think that really affords itself to a new level of being in tune in those meetings, and really a new level of respect for clients. I really value that and like that part of the practice. I think how many times do we talk about clients when they're not present? And it's not in a bad way. It's trying to figure them out. Usually it's trying to figure out what intervention should I use, or how can I better do this? But what an opportunity it creates for a therapist if you're not having conversation about your clients until you're with them. If you're not having clients until you're in front of them, you have to be so in tune with what's going on. So in here I have some trainings. These are the trainings that I was telling you about, the websites. So the Institute for Dialogic Practice, you can read them. I don't need to go over them with you, but those are the opportunities for you guys to be able to have some trainings if you're interested in this practice, which hopefully you will be. You'll at least explore it a little bit. Barriers to implementation, as I said, the training, it does take time to train. It's not that much for the 2-day course. It's about $300. It was not a lot of money. It's not bad at all. The biggest issue, I think, with one of the biggest issues with implementing this in the US is obviously reimbursement, because other than PACT and hospital, 2 therapists per session, you're never going to get any insurance to pay for that. Response times are within 24 hours. That is very difficult for individuals to do, obviously. tolerating uncertainty in the paradigm shift. And I will say, there are people, I have tried this modality of treatment with a few individuals, and they just were not open to it, and they did not like it, and they didn't like being in a room with people. And you know, you have to respect people's wishes. Obviously, we all know that. So there are people that this approach will not work for, and you have to listen to the client and listen to yourself when it comes to that. Research and fidelity measures, there has been some research done. I will say the research, a lot of the early research was done by the developers of the model. So I'm not sure how evidence-based, I'm not sure how rigorous that research was. But I will say that the research did say that there was a 30% drop in the use of neuroleptics. There was like a 45% drop in hospitalizations for individuals who are willing to utilize this treatment. Again, the research was done by the developers, and they were comparing it to treatment as usual. So I don't think it was the best research ever done. I will say that, but I think it's worth looking into. There is an ODESI trial, and I'm going to try to see what ODESI stands for. I have it written here because I can never remember. Open dialogue, development, and evaluation of a social network intervention for severe mental illness. And this is a long-term study that was done. Professor Stephen Pulling did a lot of that research. So I encourage you, I'm not going to talk about that now, but I encourage you to go study that, look that up if you're interested in it, because I think it's an interesting trial. And then there's a couple of fidelity measures that Open Dialogue has. They're called the ODAS and the COMFIDE. The ODAS is Open Dialogue Adherence Scale. So if you were watching me do an open dialogue session, you would have in front of you the Open Dialogue Assessment Scale if you were rating me through a two-way mirror. And you would be looking for me to be, am I getting the family to participate? Am I using open-ended questions? Am I emphasizing the present moment? Am I responding to discourse in a matter-of-fact style and with meaningful dialogue? Am I being transparent? And you would rate me from not acceptable to excellent in those things. And that is how kind of you measure people's adherence to the model. And then there's the COMFIDE, which is let me see, I have a paper here because I can never remember that either, the Community Mental Health Fidelity Scale. And that just measures a lot of the community mental health engagement, the team structure and the culture, the assessment and engagement, the delivery, the external supports, team ethos, training, do people have the training, the staff satisfaction and team cohesion. So there are some fidelity models and measures involved with this that I think are really interesting and good for you guys to know about and look up on your own. I've included in these slides some research for further learning so that you can go study this on your own if you have a desire to do so. Again, I do think it's a really neat model. And then I wanted to talk just a little bit about open dialogue as a tool to address racism and cultural mistrust. I've told you multiple times that it is a flattening of the hierarchy, right? Service providers are not the experts. It is a network approach. It builds a system of support, hopefully around the person. And social construction and meaning of crisis and symptoms are created in these meetings. We're not telling people what the meanings are for them. And then the transparency. So I really think that it really levels the playing field and makes the people the experts in their own lives, as I've told you multiple times. And that's really the training that I have for you guys. I don't know what questions you have. Will it work in the corporate world? Oh my goodness. I don't know. That's a great question. Jessica asked that. Jacina? Yeah. Tell me more about that question.
No, I'm saying like for issues in group cohesion, if they have a meaning, like let's say that they have a group project and they need to get along, and then they have issues, so get them together so they could get along and try to produce.
Absolutely, I think you could try it for that. I think that would be a good use. Maybe I'll try that.
I figured that with open dialogue, with them trying to figure out, you know, what their issues are.
Yeah, absolutely. I mean, it is about opening up the dialogue and getting people to speak in a group setting, and then having the therapist reflect on what they've heard. I think would be really an interesting practice. I think that maybe I'll try it in my teams. Thank you.
Sarah, I have a question.
Yes.
Um, Two things. I'm not familiar with this model at all. It just happened that yesterday in my serious mental illness elective, we happened to be watching a short video on people experiencing auditory hallucinations in England. And they just happened to be talking about using open dialogue. So, question, do you feel like this is something that maybe is being used more outside of the United States?
Yes, it is.
Okay.
In Finland, it is a system of care, and in England and other places, it's utilized in a lot of hospital settings, a lot of clinical settings. It is far more prevalent in European countries that it's being utilized than here.
Okay. And then last question, could you tell us a little bit about how the family genogram is used and why?
Sure. I think that the family genogram is for you to become in touch with your own self, your own family history, so that when you're doing this work, you're very self-aware, right? You're very self-aware. The transference, you know, you can't have a lot of transference in this when you're doing this type of work with individuals, because it gets in the way and you miss it. You have to be so self-aware and so focused. So I think the use of the genogram really is just for you to be comfortable with who you are, have yourself grounded, so that when you walk into these meetings, you are not triggered by things people say, and that you can be fully present and in the moment with your clients. If that makes sense.
Mm-hmm. It does. And there's a question in the chat, and it asks, how does US-based open dialogue differ from how it's implemented in Finland, if at all?
I think that it's just more prevalent. It's much more common. I was doing some research, and you know how we have what to expect at your first appointment at your pediatrician, or if you go to the CSB, you have a what to expect at your first appointment. In Finland, they have a what to expect at your first network meeting, which I think is a really cool component, and I think really neat, because it is that prevalent in that country. So I'm not sure as though it's different. I'd imagine that they're much better at it, because they've been practicing it, especially up in the Torniana region of Western Finland since, you know, the 1980s. So I imagine that they're probably very skilled at it. Whereas I think here, it's the folks that are doing it haven't been doing it as long. Perhaps some of them have been more extensively trained, because they've gone. A lot of people, when it that first did this in the U.S., Mary Olson, LSON, is a pioneer. She had a open dialogue clinic and practice in Vermont, and then moved that to New York City. And she did all of her training in Finland. And I think a lot of people that are training now in the US did go there to receive the initial training. So I'm not sure it's different. I just think that it's more incorporated in their culture, if that makes sense.
I think Sarah has time for one more question, if there's one more question in the chat. Or, sorry, not in the chat, I apologize. If anyone has one more question at all for Sarah. Oh, there's one more question.
One more.
Oh,
I'll be orderly, but I have one more question.
okay. Yeah, and there's one question in the chat, so maybe we can do two. So if you want to go first, and then I'll read the one in the chat. Okay. Go for it.
I think the one thing, as I've been listening to this really such a kind of thought-provoking session, I keep thinking, okay, what can I start doing? What can I take from this? You know, if I'm not able to get, you know, the full depth of training, or, you know, I definitely want to watch more of this video and get more exposure. But what would you say are any kind of tips for us that, let's say, Is it, what can we start doing tomorrow to start even shifting the way we think
Yeah.
when we're
I
in
think
sessions?
I'll tell you, I don't have my books here. I read two books on this practice that really helped ground me and help me understand it better, because we have such a short time for me to tell you about this practice. But I really think being self-aware, which I know you all are, but being really self-aware in your sessions and just remembering that your clients are the experts in every single session that you're having. And when it's appropriate in your clinical setting, bringing in families and really engaging them in treatment and the treatment as the client allows you to do, and engaging in conversation, that generating that conversation and just being present with folks, just really being present with individuals. And if you are able to have another therapist in the room, or if you're able to do that and then doing that reflection, I think that is really important and a huge component of this model. So if it doesn't have to be a therapist. You have somebody else that's a peer. I'm not sure where you work, if you work in a hospital or where you work, but if you could have somebody else and kind of do that reflection with the family present, I think that is huge. I think I have a couple of books that I'll send the titles to Cassie too. They might be in they're in my references. The books that are really good, that kind of helped me understand and ground me in this, are in the references. So read the books that are in the references. I
Thanks,
hope
Sarah.
that.
And yeah, I will send out the
I love your
slides.
picture. I loved your picture in the background, by the way.
And the last question is, are there any additional considerations involved for using this model with a young person? And that will be the last question.
Actually, it's very prevalently used in first episode psychosis in young individuals. It is very prevalently used in that population, for individuals between the ages. I don't know if it's used in children. I've never seen anything about it being used in children. So it could be. It's just that I'm not aware of it. But I do know that young adults ages 14 to 21, there's in Stride, there's a intervention for early psychosis modality of treatment that uses open dialogue a lot, both in America and definitely in Europe. So I have seen it used there. Yes.
Well, that is going to wrap us up for tonight. So, if you haven't filled out the attendance link, it is in the chat. Thank you so much. I'm trying to stop my dog from eating my chocolate cupcake that my partner brought me. Literally, she's like, right. I just, Thank you so much, Sarah. This was absolutely phenomenal. We collectively, I think, were completely engaged with what you presented to us. Um, Thank you, thank you, thank you so much. For those of you that are here for the first time, this is part of a series. In 2 weeks from now, we will have Nicole Jiggets come and present. Nicole will be talking about the power of play and innovative techniques in child therapy. So please, please sign up for that if you have not already. We look forward to having you as the audience. Please come to the rest of this series. We will have 5 more ahead of us this spring semester. So thank you all for being here with us tonight. We're glad you were here. And Sarah, again, thank you so much. And
Thank
everyone
you for
have a
the
good night.
opportunity.
Yeah,
Thank you.
thank you, Sarah.